Hi, good day, and welcome to my lecture on amniotic fluid. This is Doc Ina. To download my lecture deck, please go to my WordPress site, Doc Ina Obigaine. References for this lecture include the following: Williams Obstetrics 25th edition, Urinalysis and Body Fluids by Strassinger, and UpToDate.com. And this is the outline of my lecture. Amniotic fluid volume increases from approximately 30 ml at 10 weeks AOG to about 200 ml by 16 weeks AOG and reaches about 800 ml by the mid-third trimester. The fluid is approximately 98% water. A full-term fetus contains roughly 2,800 ml of water and the placenta another 400 ml, such that the term uterus holds nearly 4 liters of water. Abnormally decreased fluid volume is termed OLIGOHYDRAMNIOS, whereas abnormally increased fluid volume is termed Hydramnios or polyhydramnios. During early pregnancy, the amniotic cavity is filled with fluid that is similar in composition to the maternal extracellular fluid. During the first half of pregnancy, the transfer of water and other small molecules takes place through the following: through transmembranous flow, which is the transfer of water and other small molecules across the amnion; intramembranous flow, which is the transfer of water across the fetal vessels on the placental surface; or through transcutaneous flow, which is the transfer of water and other small molecules across the fetal skin. Fetal urine production begins about 8 to 11 weeks AOG. So after the first trimester, the fetal urine is the major contributor to the amniotic fluid volume. At the time that fetal urine production occurs, fetal swallowing of the amniotic fluid begins and regulates the increase in fluid from the fetal urine. Water transport across the fetal skin continues until keratinization occurs at 22 to 25 weeks AOG, and this explains why extremely preterm neonates can experience significant fluid loss across their skin. There are 4 major pathways that play an important role in the amniotic fluid volume regulation. And as the first one is fetal urination, as I've already mentioned a few slides back. And this is the primary source of amniotic fluid in the second half of pregnancy. By term, fetal urine production may exceed 1 liter per day, and the entire amniotic fluid volume is recirculated on a daily basis. The second pathway is through intramembranous fluid transfer. The hypotonicity of amniotic fluid accounts for significant intramembranous fluid transfer across and into fetal vessels on the placental surface. This transfer reaches 400 ml per day and is a second regulator of fluid volume. In the setting of maternal dehydration, the resultant increase in maternal osmolality favors fluid transfer from the fetus to the mother and then from the amniotic fluid compartment into the fetus. The third pathway is through the fetal lung fluid secretion or the respiratory tract. Approximately 350 ml of lung fluid is produced daily during late gestation, and half of this is immediately swallowed. A fourth major pathway is through fetal swallowing, which is the primary mechanism for amniotic fluid resorption and averages about 500 to 1,000 ml per day. Impaired swallowing, either secondary to a CNS abnormality or a GI tract obstruction, can result in an impressive degree of polyhydramnios. We also have a minor pathway, and these are the transmembranous and transcutaneous flow, which together account for a far smaller proportion of fluid transport during the second half of pregnancy. The average fluid volume is approximately 400 ml between 22 and 30 weeks, and it doubles thereafter to a mean of about 800 ml. The volume remains at this level until 40 weeks and then declines thereafter by approximately 8% per week. As for the sonographic assessment of amniotic fluid volume can be clinically measured using either of 2 semi-quantitative techniques. Either we do an SDP or a single deepest pocket of fluid, or an AFI, which is amniotic fluid index. Using either technique, a fluid pocket must be at least 1 centimeter in width to be considered adequate. Fetal parts or loops of umbilical cord may be visible in the pocket, but they should not be included in the measurement. Color Doppler is generally used to verify that umbilical cord is not within the measurement. Let's first discuss SDP, or the single deepest pocket. This is also called maximum vertical pocket or the largest vertical pocket. This is the vertical dimension in centimeters of the largest pocket of amniotic fluid not persistently containing umbilical cord or fetal extremities and measured at a right angle to the uterine contour. The ultrasound transducer is held perpendicular to the floor and parallel to the long axis of the patient. Then, while scanning in the sagittal plane, the largest vertical pocket of fluid is identified and measured. The normal value for SDP is more than 2 centimeters and less than 8 centimeters. When evaluating twin pregnancies in other multifetal gestations, a single deepest pocket of amniotic fluid is assessed in each gestational sac, again using a normal range of more than 2 centimeters to less than 8 centimeters. The fetal biophysical profile similarly uses a single deepest vertical pocket threshold of more than 2 centimeters to indicate normal amniotic fluid volume. Another method is through AFI, or the Amniotic Fluid Index. We do this by placing the ultrasound transducer perpendicular to the floor and parallel to the long axis of the woman. The uterus is divided into 4 equal quadrants: the right upper quadrant, the left upper quadrant, the right lower quadrant, and the left lower quadrant. So the AFI will be the sum of the single deepest pocket from each of these quadrants. A useful guideline is that the AFI approximates 3 times the single deepest pocket of fluid. The AFI is generally considered normal if greater than 5 centimeters and below 24 or sometimes 25 centimeters. Values outside these ranges indicate OLIGOHYDRAMNIOS and Hydramnios respectively. The upper threshold of 24 centimeters is used in most consensus guidelines such as the ACOG. And here's the criteria for mild, moderate, and severe polyhydramnios using either SDP or AFI. So for SDP, mild polyhydramnios is defined as 8 to 11.9 centimeters. Moderate polyhydramnios uses a SDP of 12 to 15.9 centimeters, while severe polyhydramnios is an SDP of at least 16 centimeters. Now, using AFI, mild polyhydramnios is about 24 to 29.9 centimeters, moderate polyhydramnios is 30 to 34.9 centimeters, and severe polyhydramnios is an AFI of more than 35 centimeters. Now, here is a published study. This is actually a randomized controlled trial that compared the SDP and the AFI as evaluation tests for predicting adverse pregnancy outcomes, and this is called the SAFE trial. And this study concluded that the use of AFI method increased the rate of diagnosis of oligohydramnios and labor induction for oligohydramnios without improving perinatal outcome. And so the SDP method is therefore the favorable method to estimate amniotic fluid volume, especially in a population with many low-risk pregnancies. This is also the reason why most OB-sonologists prefer using the SDP method in measuring amniotic fluid volume. Now we talked about polyhydramnios or hydramnios. This is an abnormally increased amniotic fluid volume, and it complicates about 1 to 2% of singleton pregnancies. This is most frequently noted among multifetal gestations. Hydramnios may be suspected if the uterine size exceeds that expected for gestational age, and the uterus may feel tense and palpating fetal small parts or auscultating fetal heart tones may be quite challenging. And these are the criteria that I've already mentioned a few slides back in diagnosing hydramnios using either the AFI or the SDP. In general, severe hydramnios is far more likely to have an underlying etiology and to have consequences for the pregnancy rather than mild hydramnios, which is frequently idiopathic and benign. The underlying causes of hydramnios include the following: fetal structural or genetic abnormalities, diabetes, congenital infection, red blood cell alloimmunization, and placental chorioangioma are less frequent etiologies. We can also include infections such as cytomegalovirus, toxoplasmosis, syphilis, and parvovirus, and of course, hydrops fetalis and severe fetal anemia. Now, for congenital anomalies causing hydramnios, because of this association, a targeted sonography is indicated whenever hydramnios is identified. If a fetal abnormality is encountered concurrent with hydramnios, amniocentesis with chromosomal microarray analysis should be offered to our patient because the aneuploidy risk is significantly elevated. The degree of hydramnios correlates well with the likelihood of an anomalous infant, and the anomaly risk is particularly high with hydramnios coexistent with fetal growth restriction. And here is a table showing to us the selected anomalies or selected fetal anomalies and the mechanism for hydramnios. So for example, the fetus was detected to have anencephaly or hydranencephaly or holoprosencephaly. So the mechanism for hydramnios in these cases will be impaired swallowing. Another example here would be a fetus with a cleft lip or palate or a micrognathia. And if we detect polyhydramnios concomitantly, then the mechanism for polyhydramnios would be impaired swallowing. Okay, another example here will be esophageal atresia or a fetus with esophageal atresia or duodenal atresia. And then if we detect a concomitant polyhydramnios, then the mechanism for polyhydramnios would be GI obstruction. And so on down the line. No? So just look at this table so that you will be familiar with the mechanism of hydramnios for each selected fetal anomaly. Now, for the association of diabetes mellitus and hydramnios, the amniotic fluid glucose concentration is higher in diabetic women than in those without diabetes, and the AFI may correlate well with the amniotic fluid glucose concentration. These findings support the hypothesis that maternal hyperglycemia causes fetal hyperglycemia, with resulting fetal osmotic diuresis into the amniotic fluid compartment. That being said, rescreening for gestational diabetes in pregnancies with hydramnios does not appear to be beneficial, provided that the second trimester glucose tolerance test result is normal. As for multifetal gestation in hydramnios, hydramnios is generally defined in multifetal gestations as the single deepest amniotic fluid pocket measuring 8 centimeters or more. It may be further characterized as moderate if the single deepest pocket is at least 10 centimeters, and severe if this pocket is at least 12 centimeters. Severe hydramnios is more strongly associated with fetal abnormalities. In monochorionic gestations, hydramnios of one sac and oligohydramnios on the other is a diagnostic criteria or a criterion for twin-twin transfusion syndrome or TTTS. In the absence of TTTS, hydramnios does not generally raise pregnancy risk in non-anomalous twins. So now we discuss idiopathic hydramnios. This accounts for up to 70% of cases of hydramnios, and this is rarely identified during mid-trimester sonography and is often an incidental finding later in gestation. The gestational age at sonographic detection usually lies between 32 and 35 weeks AOG. Although it is a diagnosis of exclusion, an underlying fetal abnormality may subsequently become apparent with advancing gestation, particularly if the degree of hydramnios becomes severe. Mild idiopathic hydramnios is most commonly a benign finding, and associated pregnancy outcomes are usually good. Now, what are the complications of hydramnios? Well, unless hydramnios is severe or develops rapidly, maternal symptoms are very infrequent. With chronic hydramnios, fluid accumulates gradually, and a woman may tolerate excessive abdominal distension with relatively little discomfort. Acute hydramnios, however, tends to develop early in pregnancy, and it may result in preterm labor before 28 weeks or in symptoms that become so debilitating as to necessitate intervention. Symptoms may arise from pressure exerted within the overdistended uterus and upon adjacent organs. When the distension becomes excessive, the mother may suffer from dyspnea or orthopnea. Edema may develop as a consequence of major venous system compression by the enlarged uterus, and it tends to be most pronounced in the lower extremities, the vulva, and the abdominal wall. Rarely, oliguria may result from ureteral obstruction by the enlarged uterus. Maternal complications associated with hydramnios include placental abruptio, uterine dysfunction during labor, and postpartum hemorrhage. Placental abruptio may result from rapid decompression of an overdistended uterus that follows fetal membrane rupture or therapeutic amnioreduction. With prematurely ruptured membranes, a placental abruptio occasionally occurs days or weeks after amniorexis. Uterine dysfunction consequent to overdistension may lead to postpartum atony and, in turn, postpartum hemorrhage. What are the pregnancy outcomes for polyhydramnios? Well, some outcomes more common with hydramnios include large birth weight, that's a birth weight of more than 4,000 grams, cesarean delivery, and perinatal mortality. Risks appear to be compounded when a growth-restricted fetus is identified with hydramnios. How do we manage polyhydramnios? Well, treatment is directed to the underlying cause. If severe hydramnios result in early preterm labor or the development of maternal respiratory compromise, then amnioreduction may be needed. So how do we do amnioreduction? Approximately 1,000 to 2,000 ml of fluid is slowly withdrawn over a period of about 20 to 30 minutes, depending on the severity of hydramnios and gestational age. The goal here for amnioreduction is to restore amniotic fluid volume to the upper normal range. Hydramnios that's severe enough to necessitate amnioreduction almost invariably has an underlying cause, and subsequent amnioreduction procedures may be required as often as weekly and sometimes even semi-weekly. Now we go to oligohydramnios, and this is an abnormally decreased amount of amniotic fluid. Now, when there's no measurable pocket of amniotic fluid that's identified, then we call that anhydramnios. Unlike hydramnios, which is often mild and often confers a benign prognosis in the absence of an underlying etiology, oligohydramnios is almost always a cause for concern. The sonographic diagnosis of oligohydramnios is usually based on an AFI that's less than 5 centimeters or an SDP below 2 centimeters. The use of AFI rather than SDP will identify more pregnancies as having oligohydramnios without evidence of improvement in pregnancy outcomes. And this is exactly the findings of that RCT that I already mentioned a few slides back. When evaluating multifetal pregnancies for TTTS, an SDP below 2 centimeters is used to define oligohydramnios. Now we go to the etiology for oligohydramnios. Now, for early onset oligohydramnios, when the amniotic fluid volume is abnormally decreased from the early second trimester, it may reflect a fetal abnormality that precludes normal urination, or it may represent a placental abnormality that sufficiently impair or sufficiently severe to impair perfusion. In either circumstance, the prognosis is poor. Ruptured membranes, of course, should be excluded, and targeted sonography is performed to assess for fetal and placental abnormalities. For oligohydramnios during the mid-pregnancy, when amniotic fluid volume becomes abnormally decreased in the late second or in the third trimester, it is very often associated with fetal growth restriction, with a placental abnormality, or with the maternal complications such as preeclampsia or a vascular disease. The underlying cause in such cases is frequently uteroplacental insufficiency, which we all know can impair fetal growth and reduce fetal urine output. Exposure also to selected medications has also been linked with oligohydramnios. Investigation of third trimester oligohydramnios generally includes evaluation for ruptured membranes and sonography to assess fetal growth. Umbilical artery Doppler studies are also recommended if growth restriction or fetal growth restriction is identified. Now, for congenital anomalies that are associated with oligohydramnios, by approximately 18 weeks, the fetal kidneys are the main contributor to amniotic fluid volume. So, selected renal abnormalities that lead to absent fetal urine production include the following: bilateral renal agenesis, bilateral multicystic dysplastic kidneys, unilateral renal agenesis with contralateral multicystic dysplastic kidney, or an infantile form of autosomal recessive polycystic kidney disease. Urinary abnormalities may also result in oligohydramnios because of fetal bladder outlet obstruction, and examples of this are the following: posterior urethral valves, urethral atresia or stenosis, and megacystis microcolon intestinal hypoperistalsis syndrome. Complex fetal genitourinary abnormalities such as persistent cloaca and cyrinomilia similarly may result in a lack of amniotic fluid. As for medications associated with oligohydramnios, so oligohydramnios has been associated with exposure to drugs that block the renin-angiotensin system, and this includes the ACE inhibitors, the angiotensin receptor blockers, and NSAIDs. When taken during the second or the third trimester, ACE inhibitors and angiotensin receptor blockers may create fetal hypotension, renal hypoperfusion, and renal ischemia, with subsequent anuric renal failure. NSAIDs can be associated with fetal ductus arteriosus constriction and with lower fetal urine production. And in neonates, NSAID use may also result in acute and chronic renal insufficiency. What are the pregnancy outcomes for oligohydramnios? While oligohydramnios is associated with adverse pregnancy outcomes, AFI of less than 5 or oligohydramnios that's identified between 24 and 34 weeks AOG is associated with increased risk for stillbirth, spontaneous or medically indicated preterm birth, heart rate pattern abnormalities, and growth restriction. Women with oligohydramnios have twofold greater risk for cesarean delivery for fetal distress and a fivefold higher risk for APGAR score of less than 7 at 5 minutes compared with pregnancies with a normal AFI. Now, what is the association between pulmonary hypoplasia and oligohydramnios? When diminished amniotic fluid is first identified before the mid-second trimester, particularly before 20 to 22 weeks AOG, pulmonary hypoplasia is a significant concern. Severe oligohydramnios secondary to a renal abnormality generally has a lethal prognosis. If a placental hematoma or chorionic abruption is severe enough to result in oligohydramnios, then we have a condition called CAOS, or the chronic abruption oligohydramnios sequence, and this commonly also causes growth restriction, and the prognosis for this condition is very poor. Now, how do we manage oligohydramnios? Well, first, an evaluation for fetal anomalies in growth is very important. In a pregnancy that's complicated by oligohydramnios and fetal growth restriction, close fetal surveillance is important because of associated morbidity and mortality. Oligohydramnios is detected before 36 weeks AOG in the presence of normal fetal anatomy, and growth is generally managed expectantly in conjunction with enhanced fetal surveillance. Antepartum management of oligohydramnios may include maternal hydration. Oral or IV hydration is associated with a significant improvement in the AFI. However, it is not very clear in studies whether this translated into better pregnancy outcomes. Amnio infusion may also be used intrapartum to help resolve variable fetal heart rate decelerations. It is not considered treatment for oligohydramnios per se, although the decelerations are presumed secondary to umbilical cord compression resulting from lack of amniotic fluid. Amnio infusion, just to be clear, is not the standard of care for other etiologies of oligohydramnios and is not generally recommended. Now, what is borderline oligohydramnios? This is when the AFI falls between 5 and 8 centimeters. Now, through the mid-third trimester, an AFI value of 8 centimeters is below the 5th percentile on the Moore normogram. This is associated with higher rates of preterm delivery, cesarean delivery for a non-reassuring fetal heart rate pattern, and fetal growth restriction. However, studies have concluded that evidence is insufficient to support fetal testing or delivery in this setting. Now, for the last part of this lecture, let's talk about tests for fetal lung maturity that uses amniotic fluid. First is the classic Lecithin-Sphingomyelin or LS ratio. This is the reference method to which other tests for fetal lung maturity are compared against. And lecithin is the primary component of the surfactants, the phospholipids, neutral lipids, and proteins, and they make up the alveolar lining and account for alveolar stability. Lecithin is reduced at a relatively low and constant rate until the 35th week AOG, and therefore increases in its production rate occurs, resulting in the stabilization of the fetal lung alveoli. Sphingomyelin, on the other hand, is a lipid that is reduced at a constant rate after about 26 weeks AOG, and therefore it can serve as a control on which to base the rise in lecithin. Both lecithin and sphingomyelin appear in the amniotic fluid in amounts proportional to their concentrations in the fetus. Now, prior to 35 weeks gestation, the LS ratio is usually less than 1.6 because large amounts of lecithin are not yet being produced at this time. Now, it will rise to about 2.0 or higher when lecithin production increases to prevent alveolar collapse. Therefore, when the LS ratio reaches 2.0, a preterm delivery is usually considered to be safe. Falsely elevated results are encountered in fluid contaminated with blood or meconium because both of these substances contain lecithin and sphingomyelin. Quantitative measurement of lecithin and sphingomyelin is performed using thin layer chromatography, and this procedure is quite labor-intensive and subject to high coefficients of variation. Many laboratories have replaced the LS ratio with the more cost-effective phosphatidylglycerol immunoassays, fluorescence polarization, and lamellar body density procedures, which we will discuss shortly. The next method is amniostat FLM, and this is based on another surface lipid or a long surface lipid, which is phosphatidylglycerol, which is also essential for adequate lung maturity. The production of phosphatidylglycerol normally parallels that of lecithin, but its production is delayed in cases of maternal diabetes. Now, in cases of maternal diabetes, respiratory distress may occur or possibly occur even in the presence of an LS ratio of 2.0, and therefore a thin layer chromatography lung profile must include lecithin, sphingomyelin, and phosphatidylglycerol to provide a more accurate measurement. Development of an immunologic agglutination test for phosphatidylglycerol has provided a more rapid method of assessment for fetal lung maturity that does not require laboratory equipment that perform thin layer chromatography. The amniostat FLM uses anti-sera that's specific for phosphatidylglycerol and is not affected by specimen contamination with blood and meconium. Studies have shown good correlation with thin layer chromatography, but with a slightly higher incidence of false negative results that may need to be followed up with further testing. The next method is foam stability. Now, until the development of biochemical techniques to measure the individual lung surface lipid concentrations, a mechanical screening test, which is called foam or shake test, was done in the past, and this was used to determine their presence. The foam or shake test is done with this procedure. So, amniotic fluid is mixed with 95% ethanol, shaken for 15 seconds, and allowed to sit undisturbed for 15 minutes. And then at the end of this time, the surface of the fluid is observed for the presence of a continuous line of bubbles around the outside edge. The presence of bubbles indicates that a sufficient amount of phospholipid is available to reduce the surface tension of the fluid, even in the presence of alcohol, which is an anti-foaming agent. Nowadays, instead of the foam or shake test, we do the foam stability test, and this is a modification of the foam test, and this uses 0.5 ml of amniotic fluid added to increasing amounts of 95% ethanol, providing a gradient of ethanol fluid ratios ranging from 0.42 ml to 0.55 ml in 0.01 ml increments, which can be used to provide a semi-quantitative measure of the amount of surfactant present. A value of 47 or higher indicates fetal lung maturity. The foam stability index has shown good correlation with the LS ratio and test for phosphatidylglycerol. The next test is the microviscosity fluorescence polarization assay. The presence of phospholipids decreases the microviscosity of the amniotic fluid. This change in microviscosity can be measured using the principle of fluorescence polarization employed by the Abbott TDX analyzer with the TDX FLM2 assay system. The TDX fetal lung maturity 2 assay is a reagent system for the quantitative measurement of the ratio of surfactant to albumin in amniotic fluid for assessment of lung maturity. This assay measures the polarization of a fluorescent dye that combines with both surfactants and albumin. The dye that's bound to surfactant has a longer fluorescence lifetime and exhibits low polarization, whereas the dye that's bound to albumin has a decreased fluorescence lifetime and has high polarization. Albumin is used as an internal standard in the same manner as sphingomyelin because it remains at a constant level during gestation. Sample results are calculated from the stored standard curve using polarization values generated for each sample, and a value of 55 mg surfactant per gram albumin or greater provides a conservative indicator for fetal lung maturity. Immature results with the FLM2 assay are less than or equal to 39 mg per gram, and results between 40 mg per gram and 54 mg per gram cannot be declared mature or immature and must be evaluated with caution. The TDX FLM2 test value correlates well with an LS ratio of 2.0 and has few falsely mature results, making it an excellent screening tool. An accurate gestational age is an important consideration in interpreting the results, and the test requires at least 1 ml of amniotic fluid. The last method is the lamellar bodies and optical density. Lamellar bodies are lamellated phospholipids that represent a storage form of surfactant. The surfactants responsible for fetal lung maturity are produced and secreted by the type 2 pneumocytes of the fetal lung and is stored in the form of structures termed lamellar bodies at about 20 weeks AOG. The lamellar bodies enter the alveolar spaces to provide surfactant and also enter the amniotic fluid at about 26 weeks AOG. As the fetal lung matures, increased lamellar body production is reflected by an increase in amniotic fluid phospholipids and the LS ratio. Therefore, the number of lamellar bodies present in the amniotic fluid correlates well with the amount of phospholipid present in the fetal lungs. The presence of lamellar bodies increases the OD or the optical density of the amniotic fluid. So, an OD of 0.150 has been shown to correlate well with an LS ratio of greater than or equal to 2.0 and the presence of phosphatidylglycerol. Lamellar body diameter is similar to that of the small platelets, and therefore lamellar body counts or LBCs can be obtained rapidly with use of the platelet channel of hematology analyzers. Lamellar bodies can be counted using resistance pulse containing, such as that employed by Coulter's cell containing or counting instruments, and lamellar bodies can be counted using the platelet channel. Samples must be free of particle contamination like meconium and blood, and a count of 32,000 or more particles per microliter represents adequate fetal lung maturity. Now, that's it for my lecture. So, in summary, we've talked about the normal amniotic fluid volume, its physiology, and how to clinically do a sonographic assessment of the amniotic fluid volume. And we also talked about the hydramnios or polyhydramnios and oligohydramnios. And we also talked about the concept of borderline oligohydramnios. And finally, we discussed some tests of fetal lung maturity that use amniotic fluid. Thank you for listening to this lecture, and please don't forget to subscribe in my YouTube channel and my WordPress site, Doc Ina Obigaine. Thank you!